Can you see me? So I think it's still morning. Yeah, good morning. Wow. Good morning. Good morning. There we go. There we go. So I want to first of all say thank you to everyone for being able to speak with this group. It is a tremendous pleasure and opportunity, but I will also remind you of what Dr. McDonald Pinkett said in the introduction, which is that I tend to roll a little harder than some of the others, and it's intentional. And a lot of the presentations up until now have focused on patient or on our vantage point to patient. This one will not directly, but it will indirectly, because my intention is to talk about something that started with the very first presentation. The very first conversation, the very first announcement this morning was about $1.1 billion. And how many of us have heard or can complete the sentence, right? No money, no mission. No money, no mission. And so we are inextricably tied together between our ability to achieve mission, our ability to impact our patient populations in the way that we'd like, and quite frankly, our ability to advance our professional goals with an environment that is, in fact, about dollars. So while we're talking about dollars, let me say I don't have any conflicts. I don't have anything to disclose. And my objectives are to be very, very transparent, right? It's to discuss the cost to healthcare organizations and healthcare providers of medical malpractice, of unethical behaviors, and of adverse activity in the public domain. So Ms. Turner talked about, and I'm going to try to say this correctly, non-maleficence. See? We have, it's part of the construct of what we're doing professionally. While I was sitting there, I put Dr. Beverly's book in my cart to purchase because the concepts are just tremendous. So we're going to discuss the professional consequences of unethical behaviors and unethical provider behaviors. We're going to describe the impact of medical malpractice cases and nuclear verdicts, and we're going to identify the consequences to public perceptions of adverse provider conduct. In other words, we're here to talk about the cost of getting it wrong. So I have one of those things of there's nothing that says continuing medical education better than the fact that you're going to hear from lawyers back to back, right? Because we're inextricably linked. And the reality of our environment is, I worked clinically for several years as a nurse, and I worked in the transplant program for a while, but I worked on the organ procurement side. And so I remember walking onto clinical units and having the providers, right? Not the patients, but the providers in the unit go, oh, here comes the angel of death. What went wrong? Why are you here? What patient are you here about? And I went from that to being in the risk management environment where I got almost the same kind of a greeting, right? When you walk up and say, hi, Dr. such and such, or hi, nurse such and such, or hi, pharmacist such and such. I'm from risk management. I want to talk to you. They go, we don't want to talk to you. So nobody was happy to see me typically on a typical day, right? But that was okay because I understood, my mantra, what I taught my staff is to make it perfectly clear that the reason why they exist, the reason why risk managers and folks like us exist is to make certain that for everyone within our organization, that their worst day, potentially, would never be their last day, right? Or we will never achieve the mission. We will never get to where we want to go. And so we've got to work on this together. But the result of that was that going into COVID-19, we sort of had this approach. And so I was absolutely thrilled when I could walk into my organization and see banners up that say heroes work here, right? How awesome is this? And I'm going, they love us. They finally love us. But it didn't hold up. It didn't hold up. And what I learned from it is that every good story needs a villain. Every good story needs a villain. So what do I mean? Okay. Are these familiar to any of you? These are social media, public domain impressions of healthcare and healthcare providers. So the Retrievals is about Yale New Haven, right? About their fertility. And that was a podcast and it was a series. Dr. Death, right? Podcast went viral. Everybody was listening to it and watching it. And Taking Care of Maya. Is anybody familiar with Taking Care of Maya? Taking Care of Maya, right? Is about the treatment of a young lady a young patient in a hospital in Florida, affiliated with Johns Hopkins University, and what happened to her, and in particular, what happened to her mother, right? Because there was this concern, right, about Munchausen by proxy and other things around the care and treatment of this little girl, and ultimately, the mother, as a result of the actions taken by the hospital, the allegation is that the mother actually committed suicide based on the allegations around her involvement with the care and treatment of her daughter. So these are all public domain, right? People are consuming this information about healthcare and about healthcare providers. The question is, do we contribute to our own perception of being villains? Are we contributing to our own villainization? And there are lots of possible answers to that question. But what I know is that folks will say, in some ways we do. And the reason why they say that is based on things like what you see in front of you now, right? So the opioid epidemic, who got blamed for that? It was, the doctors are prescribing all of these opioids, the pharmaceutical companies are pushing out all these pills, and the doctors are passing it through, and now we've got pill mills where people can come in and just pick up a prescription, and we're contributing to it. We're contributing to it in terms of what people perceive as the cost of their healthcare and who gets rich and who's making money off of healthcare at any given moment in time. We're contributing to it. Some would say, again, we're forcing each other to be in these horrible situations that we had this tremendous perception during COVID. And then what we found on the other side of COVID is that we had burned out clinicians. We had burned out providers. They didn't want to be in healthcare anymore. Folks were walking away saying, I can't do this anymore. I'm done, right? And so then you see this burnout and you see all of these things. But we also get this from the patient perspective where folks are saddled with what's the number one leading cause of bankruptcy in America? Medical debt, right? And so people are being told that their financial ruin is based on the healthcare system and how the healthcare system works. They're being told that we're at fault for that, right? That their pocket, my deductible and my copay has gone up. I've never had it go down. Have you? So the out-of-pocket expenses associated with healthcare, just another example of folks believing that healthcare and healthcare providers are actually taking from them in a literal sense, in terms of dollars and cents that healthcare is taking from them. And then you add to that fact that we are seeing certain healthcare organizations, not all, but certain healthcare organizations are reporting what? Record profits. To the billion, with a B, billion-dollar level. And we're seeing healthcare executives, the leaders of healthcare systems with salaries and compensations that mirror that of professional athletes, right? That you've got a $35 million annual compensation package, and it's for a healthcare or a health plan CEO. And so people are not necessarily believing that healthcare is suffering or healthcare providers is suffering or the challenges of healthcare organizations. So to move forward in the story, behind every villain lies a broken heart. What do I mean? This breaks my heart. What's your overall impression of doctors? This is from a jury research firm. This is jury research work. So you think 79% positive, that's a very good thing. What broke my heart was that only 17% had a very positive view of doctors. Only 17%, and 4% were willing to report that they had a negative view. If you look at the adjacent slide, the thing that stood out for me about this slide is Ms. Turner used to tell me all the time, because she's a darn good lawyer and a really good trial attorney. And she used to tell me all the time about needing to take the jury on this story, right? We need to take them through our story. The problem is this: according to the jury research, do doctors care about their patients? 40% are neutral. 10% disagree. 2% strongly disagree. Only 39% agreed, and only 8% strongly agreed. So basically, you've got a 50-50 split between neutral and negative and positive. 50-50 split. Broke my heart. Try as they might, doctors cannot prevent bad outcomes from happening to patients. Another pretty much 50-50 split. 40% agree, but 34% neutral, 12% disagree. This is turning into a 50-50 split. Why? There's no room for mistakes when it comes to the practice of medicine. Look at the split. 37% of people agree with that statement. 14% of the jury research pool strongly agreed with that statement. And this is a personal problem for me, because I am so annoyed with TV medicine, right? They really do believe it's all supposed to be perfect. They really do believe the problem is supposed to be resolved within that 55 minutes of their time. Going back to my transplant days, it used to infuriate me that every time somebody came into the ER or into a healthcare situation and they needed a transplant, what would happen within the next 2 commercials? Somebody would show up in the condition necessary that they could provide that organ. The recipient shows up and needs it, and 2 minutes later in the story, a donor's in the same emergency department. TV medicine magic, but it just doesn't work that way. But what we've done is create a perception that we don't make mistakes, that there shouldn't be anything that goes wrong, and that it all should be fixed. So this is not a realistic environment. So what does that translate into? This is what jurors are saying. 76% believe that corporate executives lie and cover up. 76%. 71%, there should be no caps on jury awards. 45%, it's okay to ignore the judge's instructions. We just want to do what we want to do here. 30%, it takes billions with a B to send a message to corporations. There's a percentage that's not on the slide. This is about what people believe and perceive about corporations or about organizations. But the other percentage that's not on the slide is that 70% of providers are now providing care under the banner of a corporate parent or owner. So if they believe that about corporations, and 70% of providers are part of corporations, whether they be for-profit or non, they're really saying they believe that about 70% of the organizations under which our providers are practicing. That's perception. So declining trust in corporate institutions, shifting in the demographics and attitudes, and the normalization of mega verdicts, the quote-unquote Netflix effect. And I'll tie this together in a second. But I am not, I always was taught, when you point the finger at someone else, that there are 4 fingers pointing back at you. So I don't blame anybody. I'm not gonna point fingers. I'm just gonna say that this research from TransRe, which is a major insurance carrier, says that what's driving this, there are 3 things that are in common: the plaintiff's bar, and the plaintiff's bar. You have a very strong, very powerful, very organized group of people who are making their living off of being able to perpetuate this reality or this pseudo-reality, as I like to say. So what are the consequences? What are the costs? When we get into litigation and when we get into defense and we get into accusations of medical malpractice or malfeasance or misconduct, we get into this world where the plaintiffs are using these tactics to absolutely strengthen their ability to come after organizations and to come after providers. So we're seeing changes in strategy that says, hey, we are going to go after these individuals. We've got a strategy that works. We're going to provide things in litigation that give juries the chance to be outraged and angry. And we're going to make sure that we make them angry enough that whatever number it takes to send you a message, they are willing to give you. And we in the earlier slide, we talked about the fact that that number, for many people, they believe has to start with a B, that it takes $1 billion number to get there. So the consequences in terms of the cost, I want to talk about nuclear verdicts. Has anybody in here heard the term nuclear verdict before? So a nuclear verdict, right, initially was defined as any jury verdict of $10 million or more. And when the court system and when we were being impacted by COVID and this perception was that, healthcare organizations and we couldn't move cases through the courts, they dropped significantly. But then they quickly rebounded. Coming out of COVID, by the third quarter of 2021, they had rebounded to near record highs. The jury verdicts, excluding the pandemic years, nuclear verdicts are actually on an upward trajectory. And this is, again, one of those percentages that made me sort of stand back. 19% of nuclear verdicts between 2013 and 2022 were mega nuclear verdicts of at least $100 million. These numbers are real. We talked about these things, $183 million for a malpractice settlement, $138 million over here for a different organization. These are impacting organizations, but these numbers are becoming mission threatening. That the size of these numbers are changing the way that organizations are having to deal with their finances and organize their money. And this is one of those things where, we talk about strategic partners all the time. For those of you who saw my information or see the logo on the slide, Aon is is an insurance brokerage firm. And so we are looking at, in the healthcare practice, as to who wants to insure hospitals, who wants to insure doctors, who wants to insure provider practice groups. And I'll just tell you that the green areas that you see on the slides coming down from 21, coming up here to 2023, the green areas are when insurance companies were making money on medical malpractice. As the slides move towards the red and the yellow, the insurance companies are not making money. And so what do you think an insurance company wants to do if they stop making money? They don't want to write that insurance anymore. They don't want to provide the coverage anymore. We can't make money off of this. Here's why they're not making money. And I don't pretend that it's as simple as this. And I don't want you to think about it from the perspective of the insurance company. I want you to think about it from the perspective of that $1.1 billion that's allocated to hospitals and health. Think about it from your ability to work in your specific practice area because you're getting insurance, and what that means when these amounts of money come out of the pool and into the hands of folks that are coming after healthcare providers and healthcare organizations. These are the 50 largest verdicts from 2016 to 2024. And remember, I told you that a nuclear verdict was 10 million or more. We don't even get close to 10 million before we get through the top 50. So on the top end of the slide, you see $535 million. You see $400+ million. Those are actual jury verdicts issued out in healthcare cases. So That's what we're fighting against in terms of how do we keep the money flowing where we want the money to be going, and attacking the missions, because what do we all know to be true? And I just, I'm so impressed by everyone that's spoken here so far. I just want to be clear, right, that when we talk about there are cuts that have to be made and things that have to be changed, where do you think they look first? It's these marginalized community, these programs, as we are sitting here now in a country where the discussion, right, is about cutting what? Medicaid. Medicaid is where the discussion is. So we need to be clear that it's the programs that are designed to impact the most vulnerable among us that become the first, typically, in the conversation about what has to go away if we've got a bigger bill to pay on this side. So, for example, if you think about it, and I grew up, I grew up in Prince George's County. That moniker that people attach to Prince George's County is, the one of the wealthiest black suburbs. Yeah, I didn't know about that. I didn't know about that. I didn't know. If there was money around, I didn't know it. But what I also knew is that the programs that meant the most to me, things like free after-school rec programs, right? Things like free music programs in the schools, right? My brother, who was absolutely fantastic at industrial arts and was in a program to become a certified mechanic, when the school system's budget got tight, guess which programs they cut? Right? And so when budgets get tight, certain programs get cut, and we all have a pretty good idea of where they start. And so these things come together in drivers of the professional liability markets, where we're seeing things like, because the environment has become so toxic, that people are burning out. They don't want to choose healthcare. And so now we're dealing with staff shortages, right? Or people say, I got to make a whole lot of money to balance this out. And so we're not going to choose primary care, right? As we see the need for over 300 primary care providers just in one jurisdictional location, right? That the demand is tremendous, but folks are like, but in order to offset the cost of all of this, I've got to make more money. Now we're talking about the burdens of the hyper specialization of healthcare, right? Where are the family physicians? Where are the primary care physicians? Where are the pediatricians? When everybody is basically saying, I can't make any money doing that, right? So we're all seeing that. We're seeing this happen in legacy issues around sexual misconduct, right? And our ability to respond when you see that folks know more about, what happened and the misconduct of a particular doctor and shows like Dr. Death than they do about the work that very good clinicians are doing every single day, because that's not getting media attention. But these cases are, and we can't deny our accountability, right? That we have to hold a certain level of integrity. It is not comfortable for us to think about talking about or presenting to or making a case for another clinician or another provider that may be doing something inappropriate, but the cost of not doing it is devastating our ability to provide care to anyone. So I won't labor on this slide. I'll just talk about the fact that, obviously there's social inflation, and we all understand that, but now we're in an environment of pure economic inflation that is driving up the cost of everything, but that includes jury verdicts. We have judicial and legislative changes. We have a volatile litigation environment where we're seeing plaintiffs' attorneys and others willing to, again, villainize providers in order to be able to optimize their recovery. And one of the things that happens, as I talked about, is that carriers do not want to be involved with this, and they're rethinking their level of engagement within healthcare and within the healthcare industry. And what do we know about an insurance company? If it's a high risk, then what do we expect? High premium, right? The cost is most assuredly going to go up the more we paint ourselves in the position of high risk. So I would argue we're not villains. I would argue that we're not the bad guys. I would argue that although we must do more work, and what you heard today about from every presenter before me about our ability to stand up, our ability to communicate well, our ability to be effective with our patients, but also our ability to be accountable amongst each other, right? That there's nothing that irritates me more than when I find out that we have had a problematic provider, and we do research into that circumstance, and folks around that provider say, yeah, we knew something wasn't right about her. We knew something wasn't right about her. Yeah, we knew. Yeah, that guy, yeah, we knew something strange was going on. And when you listen to the podcast, if you decide to do it, I'm not going to encourage you to, but when you listen to podcasts like Dr. Death, that's what outrages our population. When you look at the retrievals, that's what outraged the population, is that people were literally saying, we knew something was wrong with her. We knew something wasn't right, but nothing happened. We can't afford to do that, and we actually have an ethical obligation to address it. So we can't run from it. And that's something that we have to do. We have to tell our story among our organizations and among our peer groups and in our professional environments, that we are taking the steps, that we are operating with integrity, and that we are doing things that make it clear that whether it's cultural competency, respect for diversity, that our folks, when they engage with our organizations, when they engage with our providers, that they actually don't walk away feeling offended. Right? You know, to Dr. Beverly's point, my husband is Guyanese, and he told one of his physician providers that he is Guyanese, and the provider's immediate response was, oh, what was it like growing up in Africa? And he said, I wouldn't know. I am from Guyana, which is in South America, and we identify as Caribbean, right? And the provider went, oh, well, what's that country then? What's the other one? And I said, I think you may be thinking of Ghana. And the provider said, oh, yeah, now that one's in Africa, right? And my husband said, we can leave whenever you're ready. This person is clueless. That was his perception. No matter how technically good that provider may have been, his perception is, this person is clueless. So we've got to deal with this in every field, right? We've got to deal with this in the media. We got to deal with this in our legislatures. As we have folks that are saying we've got to allocate more funds to make our communities healthier, I'm also saying when you do that, make sure that you're also willing to have the conversation about tort reform and protecting our institutions and protecting our providers in litigation and in lawsuits, because we got to have people to do the work if the work is ever going to get done, right? So again, we have to tell our stories. We have to advocate for ourselves and for the standards that we maintain. I started off this presentation with 3 examples, right? From Yale New Haven, from Johns Hopkins, right? And others. I just want to finish it in full circle. The headlines that you see here, they're very, very positive. It reflects very, very good work. They're also from the exact same 3 organizations that I started with. How much media attention did the good work get versus the villainizing work? We have got to do a better job of telling our story, because the work that we do in these circumstances, in my opinion, define who we are as providers and as professional organizations. And these are the stories that are being undertold. In the same way certain populations are being undertreated, certain professional population stories are being undertold and undersold. And I think that healthcare providers are among those. That is my story, that's my purpose for being here, and my purpose for connecting the dots is to say, when you look at things from 500 million to 45 million, and you start talking about how we protect our communities, how we protect our populations, how we reach the underserved, how we stay diversified, and how we continue to maintain ground, I'm going to tell you that it takes money to move the needle, and I would rather that money be moving the needle for you in that way than us moving the needle for plaintiffs' attorneys that can celebrate a $500 million verdict. My sermon is officially over.